All right, everybody, we're back for our last presentation of the day, at least. I'm Dr. Cesar here for mechanical ventilation. I'll say your name right. Thank goodness you just said it to me 20 minutes ago. My memory these days. All right, all yours, Doc.
My name's Ben Cesar. I'm a third-year resident at Freeman Health System, emergency medicine residency. I'm going to be talking to you about mechanical ventilation, really talking to you about the basics, sort of getting a ventilator set up, basic settings, basic modes. We'll get started and talk about why would you intubate a person. There's several reasons, obviously. You have to look at the patient and see, are they protecting their airway? Does it look like they are able to breathe on their own? Are they having any sonorous respirations? Are they do they look cyanotic? Are they blue? So you want to first protect their airway if they can't protect it themselves. If their metabolic demand is outstripping their physiologic reserve, then you're going to have to supplement their oxygen, intubate them, or if they're just too combative, they're a danger to themselves or danger to others, they won't let you completely evaluate them, then you may need to intubate them, put them on a ventilator. So what does the ventilator actually do? It simulates breathing, and the 4 stages of breathing that we normally experience when we're not intubated would be a little different when you're on a ventilator. So the first step is that something triggers the ventilator to give you a breath. So depending on how it's set up, either the ventilator will have a trigger or the patient themselves, as in a normal setting, will take a breath and start this process of delivering a breath. Secondly, the ventilator will actually deliver that breath after it's triggered. How much and what the composition of the gas is will be dependent on your ventilator settings. And the third step is going to be the ventilator will cut off and stop delivering the breath. And again, that's dependent on your ventilator settings. And fourth, the ventilator will open up a valve and let the air out, allowing expiration once that breath is completed. And this is usually passive. All it does is open a valve and the body naturally exhales. So when you're setting up the ventilator, you have 2 basic goals in mind. You're trying to meet their metabolic oxygen demand. So in a person who's hypothermic, they've been exposed to the elements, that might be fairly low. In someone who's septic, has a fever, that might be fairly high. So you'll need to adjust your minute ventilation to meet that oxygen demand. So the minute ventilation you can think of as the tidal volume times the respiratory rate, how often they're breathing in a minute. A normal minute ventilation, 5 on the low side and 10 on the high side, 10 liters per minute. So also you want to watch out for the negative things that you can cause with a ventilator, minimize any complications. So you don't want to deliver too much volume into the lungs that can't handle it. You can cause a pneumothorax, cause a hole in the lung, or you can cause decreased blood output from the heart. So you're going to want to monitor the patient as you put them on the ventilator and look for any signs of complications and fix them as they come up. hopefully prevent them. So there are 8 large categories of ventilator setting. Some of these are pre-programmed into some most modern ventilator systems. So the first is going to be your breath type. The second is going to be the trigger, what makes the ventilator go off and start that breath, how quickly, how many times a minute the ventilator goes off, the respiratory rate, the inspiratory to expiratory ratio, so how long is spent delivering the oxygen into the lungs, and how long is spent allowing for exhalation. And the flow, how fast the gas moves into the lungs. Cycling, so at what point do you switch from inspiration to expiration. Positive and expiratory pressure, so that's the pressure during exhalation that you maintain to hold open the lungs and the alveoli to allow gas exchange. And then finally the fraction of inspired oxygen. So that's going to be of the gas that you're putting in the lungs, what percentage of that is oxygen. So first, a ventilator setting was the breath type. There's 3 types. There's the mandatory, so that's completely controlled by the ventilator. So the ventilator triggers the breath, it delivers the breath, it stops the breath, allows for expiration. Then second is an assisted type of breath. This is started by the patient, so they take an inhalation. It can be fairly shallow, but they start the breath, and then the ventilator helps deliver that breath with pressure, and it has a setting where it will stop that breath and allow for expiration. Third type of breath is a spontaneous breath. So this would be someone who maybe you're weaning from the ventilator and you're thinking about extubating them, but you're letting them start their own breath, take the air into their lungs, and then exhale all by themselves. More physiologic. So the next ventilator setting is a trigger, as talked about earlier. So there are 2 main types of triggers. One is a pressure trigger. So that's when the patient takes a breath in, depending on your trigger sensitivity, normal is -1 to -3 centimeters of water. Usually this is pre-programmed to do a ventilator, but there has to be some sort of trigger for the breath to be started. So taking a breath in creates a negative pressure in the ventilator circuit, and that will start the breath. Or alternatively, you can have a flow trigger, and in the ventilator you'll have constant gas flowing through the circuit to the patient. And again, basically as you're having a natural inhalation, you'll have a change in the flow rate, and that will trigger the breath. So there are problems that you can run into by setting the trigger too high or too low. Again, these are usually set by the ventilator themselves, so you don't have to worry about it. But if you set the trigger too low, the ventilator will keep delivering breaths. If you have any type of variation in your breathing, it'll just keep giving you breaths, make you hyperventilate, cause respiratory alkalosis. On the other hand, if the trigger is too high and it's requiring a large pressure change to deliver the breath, then it might never register that the person is trying to take a breath. It will never deliver a breath. Eventually, the person will wear out or be locked out from getting any air. The next is pretty self-explanatory, the respiratory rate. So this is how many breaths you take a minute. You want to adjust this to the disease process. So when you have a person who's pretty acidotic, something like DKA, you're going to want to have a fairly high respiration rate. You're going to want to match the respirations that they were having before you intubated them. Or you have your average run-of-the-mill patient that is not being intubated for a lung issue or is not acidotic. You could have a normal respiratory rate that you would see in any other patient, 12 to 16 respirations a minute. Next is going to be your inspiratory to expiratory time, or the I to E time. So obviously a respiratory cycle is made up of inspiration and expiration. Your inspiratory time mathematically is the tidal volume over the flow rate, how quickly the gas is delivered. So with that mathematical relationship, you can see that if you decrease the tidal volume, you'll also decrease the inspiratory time, and that way you would decrease the I to E ratio. And on the other hand, if you were to increase the flow rate, you do the same thing. You decrease the inspiratory time, you decrease the I to E ratio. So a normal I to E ratio is going to be something like 1 to 2 or 1 to 3. You normally exhale longer than you inhale by 2 or 3 times. But you're going to want to, again, adjust this based on the disease process. So if this is someone with COPD, asthma, they have obstructive lung disease, they're very tight in their lungs and their airways, so you're going to give them more time to exhale. The I to E ratio is something like 1 to 4, 1 to 5. This is going to allow exhalation of all of their air, so it'll prevent the buildup of pressure within the lungs. On the other hand, if you have a patient who has low lung compliance, something like interstitial lung disease like pulmonary fibrosis, they develop acute respiratory distress syndrome, then you want to flip the normal I to E ratio inverse. So you have something like an I to E ratio of 2 to 1 or 3 to 1. Longer inspiration than expiration. The next ventilator setting is going to be the flow. So this is how fast the air is delivered into the lungs. Standard flow rate 60 liters per minute, but you may want to adjust this based on their disease process, again, up to 100 liters a minute. So this will allow for a short inspiratory time, a long expiratory time. Again, this is something like the I to E ratio that you'd want in a COPD patient. Next is going to be cycling. So what is telling the ventilator to go from delivering the air, inspiration, to letting the air out, expiration? So the most common cycling mode is going to be volume. So you tell the ventilator to deliver a certain volume. After that's delivered, then it'll switch to expiration. Pretty straightforward. You do have alternatives to this. There's a flow cycling, which is going to deliver a certain pressure into the lungs and then switch to expiration. This is if you're trying to protect someone from having very high pressures in the lungs and causing something like a pneumothorax. Then lastly, you can have just time cycling. So you have a certain inspiratory time and then switches to expiration. So you can really set your I to E ratio. Next ventilator setting is your positive end expiratory pressure, or PEEP. So this is the pressure delivered into the airways through the ventilator during exhalation, during expiration. So this is to help keep the lungs open even while you're exhaling. This is going to really decrease the work of breathing. It improves oxygenation. You're going to need less oxygen to oxygenate them. So a normal PEEP physiologic would be about 5 centimeters of water. So typically you would start at about 5 centimeters of water and dial up from there. If you have someone with interstitial lung disease, something like pulmonary fibrosis, you may want to increase the PEEP, keep the lungs open. Next is going to be your fraction of inspired oxygen. So again, this is fairly straightforward. This is the percentage of air that is oxygen that you're delivering into the lungs. So whenever you put someone on a ventilator, you want to start them on a fraction of inspired oxygen of 100%. And then you dial down once you know that they're oxygenating well. So your goal is to get an FiO2 below 60% to prevent the toxic effects of oxygen. So you'll want to guarantee that you have an oxygen saturation of 90%, some would say 92% at least, before you start dialing down to a lower FiO2. So next is going to be your ventilator modes. These are broad categories, and there are several of them. I'll talk about the most commonly used. Really, with all the different modes and settings, you have about 178 different ways of ventilating someone. None has been proven to be more effective than another. It's really going to be case dependent, and you're going to have to think through the disease process and their physiology and what you're trying to accomplish. So the 3 common ventilator modes are assist control ventilation, the synchronized intermittent mandatory ventilation, or SIMV, and then pressure support ventilation, which is also combined with SIMV often. So with assist control ventilation, you are going to have to set certain parameters. You're going to set the respiratory rate. The patient is allowed to breathe faster than that, and each breath that they try to initiate, the ventilator will help them. So this reduces their work of breathing if they seems like they're wearing out. But if they are not initiating breaths, this will also deliver breaths at a certain rate. It won't go below the set rate of breaths. So the disadvantage of this, it can cause with a ventilator assisted breath with every single inhalation, you have the possibility of increasing pressure within the chest. This is going to decrease cardiac output, and ultimately can cause lung injury. Then there are 2 basic decisions that you have to come up with when you are choosing assist control ventilation. Do you want this to be volume cycled, or do you want this to be pressure cycled? So if you were to choose volume cycled, you will choose the tidal volume, you will choose the flow rate, and then whatever pressure it takes to deliver that volume, to open up those lungs, it's going to use that pressure until it achieves the tidal volume. So obviously you can have very high pressures in the lungs in this case, and it can cause lung injury. Your other choice is you can choose a pressure cycled assist control ventilation. This is where you set the pressure. You don't want to go above a certain pressure to prevent lung injury. You tell it how long you want to have inspiration and expiration. So this is protective to the lungs, but you don't have a guarantee that you're going to get a tidal volume that will achieve a minute volume that will deliver the amount of oxygen that the person needs to meet their metabolic demands. Next is SIMV, synchronized intermittent mandatory ventilation. So again, you're going to set a base respiratory rate. This is the minimum amount of times that the ventilator will deliver breaths. So in this case, the patient themselves can have their own spontaneous intermittent breaths. This is a breath that's not supported by the ventilator. It's just the normal inhalation exhalation cycle with no extra pressure. So this can increase the work of breathing, but the positive is that your respiratory muscles, your diaphragm, your intercostals, everything is still going to get a workout, and you're going to be able to keep that lung, that breathing function. So when you want to take them off the ventilator, they'll be more ready. So when you don't have this significant amount of pressure delivered from the ventilator with every breath, you will have less pressure within the chest, you'll have better cardiac output, you'll have less airway pressure and less cause of barotrauma to the lungs, less chance of a pneumothorax. And often this is combined with pressure support ventilation, which I'll talk about next. So in pressure support ventilation, each breath has to be triggered by the patient. So this is going to be a patient who's awake, who's not paralyzed, who is not heavily sedated, and they have their own respiratory drive. So this is often used when you're trying to wean a patient from the ventilator. So this would not likely be used EMS, but this is a it partially supports the patient's inherent inhalation exhalation. So it doesn't have to do, you don't have to do all the work. You don't have to work against this long tube in your mouth. You don't have to work against all the tubing of the ventilator. It's going to give you a little bit of pressure, but ultimately it's seeing if the patient is ready to be extubated. So in general, there are a broad settings that you could argue are appropriate for certain situations. Again, it's going to be patient dependent, and it's going to be a combination of their pre-existing lung condition, their current disease process, what type of medications are on board. But in general, a person without lung disease, the person that you've paralyzed maybe to protect their airway, you can use an assist controlled mode. Generally, a tidal volume of 8 milliliters per kilogram of ideal body weight is going to be a good starting place for dialing in tidal volume. The respiratory rate is going to be pretty much like a physiologic respiratory rate, so something like 12 to 20 breaths a minute. Normal inspiratory flow rate is 60 liters a minute. Again, you're going to start the FiO2 at 100% and titrate down as long as you're maintaining a pulse ox greater than 90 or 92%. Try to get your FiO2 below 60%. And you're going to want a PEEP of at least 5 to 10, somewhere in there, centimeters of water. So that's the person with no lung disease, the person you've, say you've intubated just to protect their airway, who's obtunded. Then you have the patient who has an acute lung injury, and you're trying to protect their lungs from further injury. Again, assist control mode's a good starting place. You're going to want a lower tidal volume. Again, 8 milliliters per kilogram is not too much, but nothing over that. You want to aim low, so 6 to 8 milliliters per kilogram, again, of ideal body weight. And the respiratory rate, something lower initially, but you can go up to meet their physiologic needs, even up to 35 respirations a minute, if that's what their physiology demands. Use a inspiratory flow rate, again, somewhere from 60 to 90 liters per minute. FiO2, again, you're going to start at 100%, titrate down below 60% to maintain an oxygen saturation greater than 90, 92%. A PEEP at least of 5 up to 10 centimeters of water. And you're going to want to, this is the most important, the protective part of this whole method, is keeping the plateau pressures below 30 centimeters of water. You don't want any more pressure inside the lungs, or you can cause barotrauma, can cause a pneumothorax, cause worsening of the lung disease. So now you say you've got the patient on a ventilator, you got all the settings, they're cruising, they're doing okay, and all of a sudden they get in respiratory distress. Or they're become hypotensive. They start bucking the vent. You want to take a look at the patient and disconnect them from the vent. That's the easiest thing to do to remove a lot of variables, and you can just ventilate the patient with a bag valve mask. If that improves their hemodynamics, if that improves their respiratory distress, then the problem's with the ventilator most likely, and you're going to want to adjust those settings. If they don't get better, then you have to look at other possible causes. So listen to their lungs. Do they have decreased breath sounds on one side? Do they have signs of a pneumothorax? Does their ET tube look like it's in the wrong place? Is it pulled back? Or does it look like it could be obstructed? You'll want to get an EKG, see if they have maybe developed an arrhythmia. So a nice mnemonic to remember these steps of looking at the patient who is on a ventilator and acutely decompensating. DOPE. So D stands for, look for, do they have dislodgement of the endotracheal tube? Is it pulled back? Is it in the right place? You can take a look and replace it if it's dislodged. Is there an obstruction of the ET tube? Is there a mucus plug or something else obstructing the ET tube? P, listen to see if they have a pneumothorax. Or E, is there some sort of equipment failure? Is there a leak in the tubing? Is the ventilator turned off somehow? Look at everything. Look at your surroundings. Look at everything they're hooked up to, and troubleshoot that. So that's all I've got today. I appreciate you listening to me. It was nice coming out and talk to you. Have a good afternoon.
All right, if anybody has any questions, go ahead and fire them off in the chat, and we'll read them out loud for Dr. Ben here. If not, we'll be just about done here. I'm gonna All right, Dr. Cesar, we appreciate you very much for coming out this morning, or this afternoon, I mean. Once all running together now, so. Thank you very much, sir. All right, guys, we're going to sign off and shut down the live feed for the day. You've got some assignments and homework to work on, so go ahead and do work on those things, and we'll be back in the morning. Y'all have a good evening.